Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator and the cardiologist. So the today's topic for the discussion for the INI-CET revision series, it is the hemoptysis. So I'll give you the various clinical scenarios and you should identify what is the diagnosis of the clinical condition which is given. And here are the options. So before going ahead with the clinical scenarios, you please answer this question in the comment section. What is the criteria to call it as massive hemoptysis? More than 50 ml per 24 hours, more than 100 ml per 24 hours, more than 100 ml per 1 hour, more than 50 ml per 1 hour. So what is the criteria to call it as massive hemoptysis? So please answer in the comment section. Definitely I will revert you back. So now coming ahead with the first important clinical scenario. So a 65-year-old smoker presents with the shortness of breath, and there is also gallop rhythm and production of the pink frothy sputum. So having gallop rhythm, breathlessness and pink frothy expectoration, this is suggestive of pulmonary edema, right? And in pulmonary edema you have the presence of the pink frothy sputum. And this pulmonary edema, it is secondary to left ventricular failure. Now, what could be the cause for the development of left ventricular failure in this individual is elderly male, and that too, he is a smoker. So, the individual would have, there is very high risk of development of the ischemic heart disease causing left ventricular failure. Now, quickly, let me recap the clinical features of left heart failure and as well as the right heart failure. Just it is a revision series, so I'll just do a quick recap without explaining you the mechanisms. So in left heart failure, please remember the earliest manifestation is the paroxysmal nocturnal dyspnea, and later they can have orthopnea and dyspnea. They will have cough with pink frothy expectoration, and when you auscultate you have the presence of bilateral basal crepitations, and there will be also gallop rhythm or even quadruple rhythm, even where S4 also can be heard. Then you take in patients with the right heart failure. In patients with right heart failure, please remember that the earliest finding is there will be elevated JVP. Now apart from elevated JVP, the other features include the tender hepatomegaly, and there will be also pedal edema. Apart from this, they will have portal hypertension causing ascites, and there will be also splenomegaly. So, and there will be fluid overload in the all areas of the body resulting in weight gain, and there will be also nocturia. So these are the features of the right heart failure. Then what are the etiologies? How do we classify the heart failure? That is based on the ejection fraction, and normal ejection fraction, it is around 55 to 70%. It is the normal ejection fraction. And heart failure with reduced ejection fraction, the ejection fraction is less than 40%. And heart failure with preserved ejection fraction, the ejection fraction is more than 50%. And reduced ejection fraction causes include dilated cardiomyopathy, coronary artery disease, valvular heart diseases like aortic stenosis, aortic regurgitation and mitral regurgitation, and parasitic infection, that is Chagas disease. And heart failure with preserved ejection fraction, the etiologies include restrictive cardiomyopathy, hypertrophic cardiomyopathy, then cor pulmonale and endomyocardial disorders, right? Endomyocardial disorders. Okay, so these are the causes for heart failure with preserved ejection fraction. So to summarize, in patients with heart failure, you will have cough with pink frothy expectoration, they will have dyspnea, they will have gallop rhythm, and they will have bilateral basal crepitations. Now coming to the second important clinical scenario. A 24-year-old man initially complaining of cough and intermittent hemoptysis, and presents with a few weeks later with hematuria also. So there is hemoptysis and hematuria, and biopsy shows crescentic glomerulonephritis. Renal biopsy shows linear pattern deposition on the immunofluorescence. So among the options which has been given to you, what is the clinical condition? So hematuria is there and hemoptysis is there. So what is this? It is pulmonary renal syndrome. It is pulmonary renal syndrome. Now what all differential diagnosis you have for this? The differential diagnosis that you have is Wegener's granulomatosis, Goodpasture syndrome, and one more condition, that is microscopic polyangiitis. Okay, that is not there in yours, right? So pulmonary renal syndrome, these are the important things that you have to look for. One is Wegener's, microscopic polyangiitis, and Goodpasture's disease. Now what is the diagnosis in that? Let me discuss. In Wegener's granulomatosis, if you see, you have the C ANCA being positive, right? And microscopic polyangiitis, you have P ANCA being positive. Whereas in Goodpasture disease or Goodpasture syndrome, the ANCA, it is negative, right? ANCA is negative. And what is there in Goodpasture syndrome then? In patients with the Goodpasture syndrome, it's an autoimmune disease. You have anti-glomerular basement membrane antibodies. These anti-glomerular basement membrane antibodies, they are directed against alpha 3 chain of type 4 collagen. So let me discuss now. Whatever the clinical diagnosis here, it is Goodpasture syndrome. Now the question is, why not Wegener's granulomatosis? In case of Wegener's granulomatosis, there should be upper respiratory tract involvement, which is most common. Then lower respiratory tract involvement should be there, and there should be involvement of the kidney. So you should have this particular triad in case of Wegener's. And in case of Wegener's, like you should have the C ANCA being positive, which is not given in your question. And another point, there is no upper respiratory tract involvement in this clinical scenario which has been given. So your Wegener's granulomatosis is ruled out. So the answer is the Goodpasture syndrome. So what are the three conditions where you have pulmonary renal syndrome? Wegener's, microscopic polyangiitis, and Goodpasture syndrome. Now you take this Goodpasture syndrome, right? What did I tell you? It is an autoimmune disease, and the diagnosis is by your renal biopsy. And what does the renal biopsy show? Renal biopsy will show you that there is classic linear staining on direct immunofluorescence. And what is the purpose of doing renal biopsy when you have anti-glomerular basement membrane antibodies is, renal biopsy will tell you the severity of the renal lesion, right? And so these antibodies, they are formed against alpha 3 chain of, right? They are formed against alpha 3 chain of type 4 collagen. Okay, so that is what you will see in case of the Goodpasture syndrome. Now, what is the HLA association for the development of the Goodpasture syndrome? That is HLA-DR2. Now, these individuals, they have the hypersensitivity reaction to alveolar and glomerular basement membrane, right? So, and which type of hypersensitivity reaction is that? It is a type 2 hypersensitivity reaction. And what are the risk factors for the development of the Goodpasture syndrome? The risk factors include mainly the smoking, that is the smokers, right? Very common in smokers. And not only that, exposure to fumes of hydrocarbons, right? Exposure to fumes of hydrocarbons, that is also the risk factor for the development of Goodpasture syndrome. Then how do you treat these patients? So please remember, smoking will increase or aggravate the respiratory symptoms. So first and foremost, very, very important is the patient should avoid smoking, and you should filter the antibodies whichever are there in patients with the Goodpasture syndrome, for which you need to do the plasmapheresis. Plasmapheresis will remove the existing antibodies. And how will you prevent the new antibody formation? That is, you need to give corticosteroids. So that is what is the treatment for your Goodpasture syndrome. Now, so second clinical scenario was Goodpastures. And you take the third clinical scenario. A 34-year-old woman originally complaining of nasal obstruction develops cough, Haemoptysis, pleuritic chest pain, and hematuria. And chest X-ray also shows multiple nodular masses. So what is the diagnosis suggestive of? So if you observe here, nasal obstruction, that means upper respiratory tract involvement is there. Cough and hemoptysis, there is also lower respiratory tract involvement, and there is also hematuria where there is involvement of kidney, and there is also multiple nodular masses. So this is what is suggestive of the Wegener's granulomatosis. So in Wegener's you have the triad of involvement, and in patients with the Wegener's, as I have said you, the ANCA that will be positive is the C ANCA will be positive in case of Wegener's granulomatosis, right? And in 50% of patients with the Wegener's granulomatosis, there is also involvement of the eye. That is in 50% of patients. And what will be that ophthalmic involvement in Wegener's? That is scleritis, uveitis and retinitis. This will be ophthalmic involvement in Wegener's granulomatosis. And when you do biopsy in patients with the Wegener's granulomatosis, biopsy will show you that there is presence of granulomatous inflammation. So granulomatous inflammation is the presence of the giant cells, and giant cells are nothing but the fused macrophages. And how do you treat these patients with the Wegener's granulomatosis? It's an immune mediated disorder, so you need to give high dose corticosteroids with cyclophosphamide. That is what is the treatment for your Wegener's granulomatosis. And Wegener's granulomatosis is what? It's a small vessel vasculitis. And what are the other conditions where you have small vessel vasculitis? That includes Church-Strauss syndrome, microscopic polyangiitis, Henon-Schollen's purpura and Wegener's. These are the 4 conditions where you have small vessel vasculitis. Now, so the third clinical scenario was Wegener's, where you have a triad. You take the 4th clinical scenario. A 22-year-old man presents with fever, night sweats, weight loss, cough, productive of cupfuls of blood. Zn stain is positive for acid-fast bacilli. So this is a clear-cut diagnosis of the tuberculosis. Why? Because in tuberculosis they will have weight loss, productive sputum, haemoptysis, and apart from all these, the Ziehl-Neelsen stain is positive for acid-fast bacilli, tells you it is tuberculosis. But in case of tuberculosis, what exactly is the investigation of choice? Investigation of choice for tuberculosis is CB-NAT. That is cartridge based nucleic acid amplification test. And this CB-NAT will not only help in the diagnosis of the organism, it also helps in making out the resistance of the tubercle bacilli to isoniazid and as well as rifampicin. So it will also diagnose the resistance as well. Then followed by that, which type of tuberculosis have poor prognosis? So it is the miliary tuberculosis which has poor prognosis. Why? Because miliary tuberculosis is what? Where the tuberculous organism from the lung parenchyma, it is widespread through hematogenous dissemination. Right? Through hematogenous route, it can be spread to urinary tract, bone, central nervous system, and that is the reason why it is considered to be having the poor prognosis. And when you take the chest X-ray of this miliary tuberculosis, you have this classical pattern called miliary pattern. So these infiltrates, if you see within the lung parenchyma, they are of the size of the millet seeds. That is the reason why it is called miliary tuberculosis. And the another name for this is also called as snowstorm appearance on the chest X-ray. And what is the differential diagnosis for the snowstorm appearance on the chest X-ray? You will have that in case of tuberculosis, and other conditions are silicosis, hemosiderosis, varicella zoster pneumonia and pulmonary alveolar proteinosis. So these are the conditions where you will have snowstorm appearance. Now, apart from miliary tuberculosis, you take like primary tuberculosis or secondary tuberculosis. In primary or secondary tuberculosis, mainly you take secondary tuberculosis. Which lobe of the lung will undergo fibrosis? It is the upper lobe of the lung which will undergo fibrosis in case of the secondary tuberculosis. Okay. Now, but you at the same time you should know what are the other clinical conditions where you have upper lobe fibrosis of the lung. That is seen in, please remember this mnemonic, PASS RR. What is that PASS RR? That is pulmonary tuberculosis, ankylosing spondylitis, silicosis, sarcoidosis, rheumatoid arthritis and radiation. These are all the conditions where you have upper lobe fibrosis. And at the same time, you should also know what are the conditions where you have lower lobe fibrosis. Right? The mnemonic that you have to remember is AFB seen in the lung. What is this AFB seen in the lung? A stands for asbestosis, F is your fibrosing alveolitis, B is bronchiectasis, S stands for scleroderma, L stands for Loeffler syndrome. So these are the conditions where you will have lower lobe fibrosis. Okay. So the fourth clinical scenario was suggestive of tuberculosis, where the acid-fast bacilli was positive, and the investigation of choice for tuberculosis will be CBNAT. Now, last clinical scenario, if you observe, a 35-year-old businessman returns from a trip abroad and collapses at the airport with hemoptysis and pleuritic chest pain. He has a sinus tachycardia and ECG shows right axis deviation. So, what is the clinical diagnosis suggestive of? See, the individual had a long air travel, that is, he has traveled abroad. So definitely when there is long air travel, the individual will be in a sitting posture for a longer period of time. That can precipitate the development of pulmonary embolism. So in case of pulmonary embolism, the presentation of the patient is usually the dyspnea. And if the dyspnea is there, the other presentation in case of massive pulmonary embolism is they directly present with the collapse. So this patient is having a collapse, hemoptysis and pleuritic chest pain. And in pulmonary embolism, what is the most common ECG finding? That will be sinus tachycardia. Now let me discuss few quick important points about the pulmonary embolism. The most common symptom in pulmonary embolism will be dyspnea. And what will be the most common sign in pulmonary embolism? The most common sign in pulmonary embolism will be tachycardia and as well as the tachypnea. Right? And what will be the most common ECG findings? ECG finding will be sinus tachycardia will be the most common ECG finding. And investigation of choice in pulmonary embolism is CT pulmonary angiography. That is the investigation of choice. And in scenarios where you cannot do CT pulmonary angiography, the second best investigation is ventilation perfusion scan in pulmonary embolism. And in pulmonary embolism, you have some important chest X-ray finding. That is the presence of a wedge-shaped infarct that is called as the Hampton's hump. Presence of prominent right descending pulmonary artery that is called Pallas sign. And presence of focal oligemia that is called Western mark sign. So these are the three important signs that you will have within the chest X-ray. And the next method by which you can diagnose pulmonary embolism is by your 2D echo. So when you do a 2D echo, you have a characteristic McConnell sign. What is McConnell sign? The apex of the heart, right ventricle, will contract, whereas the wall of the right ventricle, it does not contract. Right? Apex of the right ventricle will contract, whereas wall of the right ventricle does not contract, and that is what is called McConnell sign that you will see in pulmonary embolism. And ECG findings, like what did I tell you? The most common ECG finding will be sinus tachycardia. The other ECG findings are right axis deviation, there will be right ventricular hypertrophy and right ventricular strain pattern. And one more important is S1 Q3 T3 pattern that is present only in 10% of patients with the pulmonary embolism. That is not the most common finding. And finally, what is the indication for thrombolysis in patients with pulmonary embolism? So if the individual is having persistent hypotension, it's an indication for thrombolysis. And if the individual is having severe hypoxemia, it's an indication for thrombolysis. And if there is right ventricular dysfunction, that is right ventricular failure, that's also an indication for thrombolysis. And if the CT scan shows that there is extensive embolic burden, if the CT scan shows extensive embolic burden, that is another indication for thrombolysis. Okay, so this is about the indications for thrombolysis in patients with the pulmonary embolism. Now, the another important treatment in pulmonary embolism is the anticoagulation. For how long you need to give the anticoagulation? It all depends upon what is the underlying risk factor which has caused pulmonary embolism. For suppose DVT, if it is provoked by surgery, trauma, estrogen or indwelling catheter, give anticoagulants for 3 months. If DVT is provoked by your, if it is like proximal leg DVT, provoked by trauma, estrogen, indwelling catheter, then it is 3 to 6 months. And please remember, what is the most common site of DVT? That is calf vein thrombosis, right? That is calf vein thrombosis. And if it is unprovoked DVT, you need to give lifelong treatment, right? And if it is a long distance air travel causing DVT, lifelong anticoagulant should be given. So these are the clinical scenarios for today. So what is the answer that you should write in the comment section? What is the criteria to call it as massive hemoptysis? More than 50 ml, more than 100 ml per 24 hours, more than 100 ml per hour, more than 50 ml per hour. Okay, so these are the clinical scenarios today, and you can also follow me on Instagram with name Rajesh Gubba, where I will be discussing MCQs every day on my Instagram handle. So thank you very much. See you tomorrow with the new set of clinical scenarios.